Today, we will be discussing cardiovascular emergencies, one of the most critical topics in emergency medical care. As EMTs, you will frequently encounter patients experiencing chest pain, heart attacks, and other life-threatening cardiovascular conditions. Understanding the pathophysiology, assessment, and treatment of these emergencies is crucial in saving lives. Chest pain is a common symptom of cardiovascular emergencies and is often caused by ischemia, a condition where there is reduced blood flow to the heart muscle. When the heart does not receive enough oxygenated blood, it begins to suffer damage. If blood flow is not restored, the affected tissue dies, leading to serious complications. Atherosclerosis is a major contributor to cardiovascular disease. It occurs when calcium and cholesterol accumulate within the walls of the arteries, creating blockages that restrict blood flow. Over time, these blockages can cause significant narrowing of the coronary arteries, increasing the risk of heart attacks. A thromboembolism is a floating blood clot that can travel through the bloodstream. If it lodges in a coronary artery, it can completely block blood flow, resulting in an acute myocardial infarction or heart attack. This type of blockage requires immediate medical intervention. Coronary artery disease is the leading cause of death in the United States. Some risk factors, like smoking, high blood pressure, and lack of exercise, can be controlled. Others, like age and genetics, cannot be changed. Recognizing and addressing these risk factors can help prevent heart disease. Acute coronary syndrome, or ACS, refers to conditions caused by myocardial ischemia, or decreased blood supply to the heart. This includes angina pectoris, which is chest pain due to reduced oxygen supply, and acute myocardial infarction, where part of the heart muscle dies due to prolonged lack of blood flow. Angina pectoris occurs when the heart's oxygen demand exceeds the available supply. It causes a crushing or squeezing chest pain but does not result in permanent heart damage. However, it should be taken seriously as it may indicate an impending heart attack. Angina can be classified as stable or unstable. Stable angina is triggered by physical exertion and improves with rest. Unstable angina occurs even without exertion and may signal an impending heart attack. Always treat angina patients as if they may be experiencing a myocardial infarction. A heart attack, or acute myocardial infarction, results in the irreversible death of heart muscle cells. These cells cannot regenerate. However, early intervention with clot-busting medications or angioplasty can limit damage and improve survival rates. Rapid transport to a hospital is essential. Patients experiencing a heart attack may show a variety of symptoms. These include weakness, nausea, sweating, chest pain, shortness of breath, and pain radiating to the jaw, arm, or back. Some may also experience fainting, irregular heartbeats, or even sudden cardiac arrest. Unlike angina, the pain from a heart attack can last much longer and is not always triggered by exertion. It can persist for 30 minutes or more and may not be relieved by rest or nitroglycerin. Some patients may not recognize their symptoms as a heart attack, which can delay critical care. Physically, AMI patients often display fear, nausea, and poor circulation. Their pulse may be fast, slow, or irregular. Blood pressure can be low, normal, or high. Some patients describe a feeling of impending doom, a sign that should not be ignored. 3 serious complications of a heart attack include sudden death, cardiogenic shock, and congestive heart failure. These conditions require immediate medical intervention and can be fatal if not managed properly. Dysrhythmias, or abnormal heart rhythms, are a major complication of heart attacks. These include premature ventricular contractions, tachycardia, bradycardia, and life-threatening arrhythmias such as ventricular fibrillation. Defibrillation is a life-saving procedure that restores normal heart rhythm. If a patient goes into cardiac arrest, CPR should be initiated until a defibrillator is available. Without defibrillation, survival rates are extremely low. Cardiogenic shock occurs when the heart is too weak to pump enough blood to sustain vital organs. Early recognition is critical, as shock can lead to multi-organ failure. Signs include low blood pressure, weak pulse, and altered mental status. Congestive heart failure often develops after a heart attack. The heart's pumping ability decreases, leading to fluid buildup in the lungs and extremities. This can cause breathing difficulties and swelling in the legs, known as dependent edema. A hypertensive emergency occurs when systolic blood pressure exceeds 180 mm of mercury. Symptoms include a severe headache, ringing in the ears, and a strong, bounding pulse. Left untreated, this condition can lead to stroke or aneurysm. Additional symptoms of a hypertensive emergency include nausea, dizziness, nosebleeds, and confusion. In severe cases, it can cause sudden pulmonary edema, leading to life-threatening respiratory distress. If untreated, a hypertensive emergency can cause a stroke or an aortic aneurysm. Patients need to be transported quickly, and advanced life support may be required. An aortic aneurysm occurs when the wall of the aorta weakens, increasing the risk of rupture. A dissecting aneurysm happens when the layers of the aortic wall separate, often due to uncontrolled hypertension. Aortic aneurysm symptoms include sudden, severe chest pain that may be mistaken for a heart attack. A key sign is a difference in blood pressure between the arms. Immediate transport is necessary for survival. When responding to a cardiovascular emergency, always prioritize scene safety. Ensure that the environment is secure before beginning patient care. Gather important clues from dispatch, the scene, and bystanders to determine the nature of the illness. Your primary assessment begins with forming a general impression of the patient. If the patient is unresponsive and not breathing, initiate CPR and call for an automated external defibrillator, AED, immediately. Assess airway and breathing, administering oxygen as needed. Patients with inadequate breathing require 100% oxygen via a bag mask device. Circulation assessment includes checking the patient's pulse, skin condition, and capillary refill. Consider treating for cardiogenic shock if needed. Transport decisions should be based on whether life threats can be stabilized. When possible, transport the patient in a way that minimizes stress. When obtaining a patient's history, focus on their chief complaint, such as chest pain or difficulty breathing. Use the sample method to gather relevant medical history and the OPQRST method to evaluate the pain's onset, provocation, quality, radiation, severity, and time. During the secondary assessment, conduct a focused physical exam, emphasizing the cardiac and respiratory systems. Evaluate circulation, breathing, and vital signs. If available, use pulse oximetry to measure oxygen saturation. Vital signs should be reassessed every 5 minutes, especially if the patient's condition changes. If cardiac arrest occurs, begin CPR immediately and use an AED as soon as it is available. Continuously evaluate the effectiveness of your interventions and transport the patient promptly. When treating a patient with chest pain, ensure they are positioned comfortably. Provide oxygen if indicated. Based on protocol, prepare to administer low-dose aspirin and assist with prescribed nitroglycerin. Aspirin is used to prevent existing blood clots from growing. EMTs typically administer chewable aspirin, with a recommended dose between 162 mg and 324 mg. Always confirm the patient has no contraindications before administering. Nitroglycerin is available in different forms, including sublingual tablets, sprays, and skin patches. It helps dilate blood vessels and improve blood flow to the heart. Nitroglycerin works by relaxing blood vessels, increasing oxygen supply to the heart, and reducing the heart's workload. This medication can significantly relieve chest pain if used correctly. However, nitroglycerin can cause side effects such as a sudden drop in blood pressure and severe headaches. Patients should be monitored closely after administration. Nitroglycerin should not be given if the patient's systolic blood pressure is below 100 mm of mercury, if they have a head injury, or if they have taken erectile dysfunction medication within the past 24 hours. Additionally, do not exceed the prescribed dose. For an electrocardiogram, ECG, to be accurate, electrodes must be placed consistently and correctly. Poor placement can lead to artifact and unreliable results. Before applying electrodes, ensure the patient's skin is dry and free of hair. Rubbing the site with an alcohol swab can improve adhesion. Attach electrodes to ECG cables before placement and confirm their positions. This slide illustrates proper electrode placement for cardiac monitoring. Following standardized placement ensures accurate readings and reliable interpretation. Once the electrodes are in place, turn on the ECG monitor and print a rhythm strip. If artifact appears on the reading, check that the electrodes are firmly attached and the cables are secure. Many patients you encounter may have had previous heart surgeries, such as coronary artery bypass grafting or angioplasty. These procedures improve blood flow to the heart and can prolong life, but these patients can still experience cardiovascular emergencies. Many patients you encounter may have had previous heart surgeries, such as coronary artery bypass grafting or angioplasty. These procedures improve blood flow to the heart and can prolong life, but these patients can still experience cardiovascular emergencies. Pacemakers are small devices implanted under the skin to maintain a regular heart rhythm. They deliver electrical impulses directly to the myocardium, preventing dangerously slow heart rates. Although pacemakers are generally reliable, they can sometimes malfunction. Signs of a failing pacemaker include dizziness, syncope, or weakness. Patients with these symptoms should be transported promptly for evaluation. Some patients have automatic implantable cardiac defibrillators, AICDs, which monitor heart rhythms and deliver shocks if needed. These devices do not pose a danger to rescuers, and patients with chest pain should be treated as if they are experiencing an AMI. Some patients wear an external defibrillator vest, which continuously monitors their heart and can deliver a shock if needed. If the vest signals an impending shock, avoid touching the patient. When performing CPR on a patient with an external defibrillator vest, the device should remain in place unless it interferes with chest compressions. These patients may also have implanted left ventricular assist devices, LVADs. LVADs help pump blood from the left ventricle to the rest of the body. Since they do not generate a palpable pulse, assessing perfusion requires checking for mental status and skin signs. Always transport these patients with their equipment and extra battery packs. Cardiac arrest occurs when the heart completely stops beating. Before the development of CPR and defibrillation in the 1960s, this was universally fatal. Early recognition, high-quality CPR, and rapid defibrillation are critical for survival. When preparing to use a defibrillator, ensure the scene is safe. Do not attempt to defibrillate a patient in standing water or in contact with metal surfaces. Before delivering a shock, remove any nitroglycerin patches from the patient's skin and ensure their chest is dry. Shaving excessive hair may be necessary to ensure good electrode contact. This slide provides an overview of the AED algorithm. The sequence of CPR, defibrillation, and reassessment must be followed correctly for the best patient outcomes. When a patient goes into cardiac arrest, begin chest compressions immediately and attach the AED as soon as possible. Follow the AED's prompts carefully. After completing the AED protocol, one of three outcomes is likely: the patient regains a pulse, the AED advises no further shocks, or the AED advises continued shocks. Each scenario requires careful decision-making and continued care. If an advanced life support (ALS) team is not responding, you may need to transport the patient while continuing resuscitation efforts. Begin transport if the patient regains a pulse, if 6 to 9 shocks have been delivered, or if the AED advises no further shocks after 3 consecutive analyses. Throughout transport, continue CPR and follow local protocols for patient care. If a patient experiences cardiac arrest while being transported, stop the vehicle and initiate CPR immediately if an AED is not readily available. Call for ALS support and analyze the patient's heart rhythm. If a shock is advised, deliver it and resume CPR. Continue following resuscitation protocols while ensuring the patient receives the best possible care. When working with ALS personnel, your role as an EMT is to provide continuous support and follow established protocols. If an AED is available, do not wait for ALS to arrive before using it. Notify ALS as soon as possible, but never delay defibrillation. Proper coordination between EMS teams ensures the best possible outcomes for patients in cardiac arrest. When a patient regains a pulse after cardiac arrest, immediate and careful management is crucial. Begin by assessing for spontaneous respirations. If the patient is not breathing adequately, provide oxygen using a bag mask device at a rate of 10 breaths per minute. Maintain the patient's oxygen saturation between 95% and 99% to ensure proper perfusion without causing hyperoxia. Monitor blood pressure closely and assess the patient's ability to follow simple commands, as this can indicate neurological function. If ALS is not already en route, begin immediate transport following local protocols. Continuous monitoring and reassessment are essential to prevent deterioration and improve the patient's chances of survival.